Thank you, Yasmin. We would also like to share with you all that Partners to Align Social Care hosted a webinar with one of our speakers today to provide an in-depth overview of the new Medicare ruling changes, which included defining the role of the codes and what types of services can be covered under the codes. We will be sharing the link to the recording as well. And we highly recommend and encourage folks to watch this webinar in order to gain a better understanding of the new ruling. Next slide, please. So our webinar today is also centered around the new Medicare ruling, but with a CHW perspective. We are focusing on how this really can contribute to the CHW workforce and how it could affect the workforce path to sustainability. So we do, from after watching this webinar, we want you all to be able to understand the role of Medicare reimbursement as part of the larger CHW sustainability strategy, and then also understand the new Medicare rule changes and how that could be used as a financial financial strategy for CHW funding. And then also understand key terms and definitions, such as knowing the difference between Medicare and Medicaid. And then lastly, we would be sharing one of our CCR 2109 recipient, what they're doing, what their state health department is doing in their CHW sustainability work. Next slide, please. With that, it's my pleasure to introduce you all to our first presenter, Angie Kuzma, from the National Association of Community Health Worker. She is the policy and advocacy manager, and then she's also a community health worker in Oregon. So I will pass it on to you, Angie.
Hello, everybody. It's so exciting to be here. Thanks so much for the introduction, Mangshi. My name is Angie Kuzma. She, her are my pronouns. And as Mangshi mentioned, I'm a community health worker based in Portland, Oregon, and I work for the National Association of Community Health Workers. So I'm just going to kind of dive right in with a little bit of framing from the national advocacy sort of perspective. And yeah, what are we all here to talk about today? Big news. In November, go to the next slide. Thanks, Mangshi. In November, the Centers for Medicare and Medicaid Services, or CMS, published new regulations that approved key benefits for the calendar year 2024 physician fee schedule. And so I don't normally like to just read from slides, but I pulled out this quote because I felt like there's just some things that struck me about it. So of course, the services that we're talking about are the Community Health Integration Services, the HI, Social Determinants of Health Risk Assessment, and Principal Illness Navigation Services. So in the final rule, you can see CMS says, medical practice has evolved to increasingly recognize the importance of these activities. This work is not explicitly identified in current coding, so we believe it is underutilized and undervalued. Accordingly, we propose to create new codes to expressly identify and value those services. So there's a few things that stand out to me about that. I mean, just one, the acknowledgement that the work has been undervalued. And of course, I'm looking at this from clearly seeing how CHWs fit into these major service categories that have been added to the benefits. But beyond that, starting to look more toward these, the opportunities and potential challenges that this exciting development presents, I'm noticing how CMS is talking about the approach here. I'm seeing the services, the work, and really we're talking about the benefits themselves and the work and the activities. They're not necessarily focused on a profession, and so that's what they're all about. That's the Centers for Medicare and Medicaid Services. So it'll perhaps make a little more sense as I go on why I'm focusing on that, but I think it's important to keep in mind as we're all digesting what this ruling means for the CHW workforce and the profession and our movement. All right. So we can go to the next slide. So the rule does address a lot more than those services. Another piece of context we need to keep in mind, what CMS was trying to do is just better recognize through coding and payment policies when members of Medicare beneficiaries receive these services and who's providing them and how to pay for them. There's no separately enumerated statutory Medicare benefit category that provides direct payment to CHWs for their services. And I'm quoting again from the ruling here. Additionally, current healthcare common procedure coding systems, or HCPCS coding, does not specifically identify services provided by CHWs, even though CHWs may facilitate access to healthcare through community-based services that are necessary to alleviate barriers to care that are interfering with a practitioner's ability to diagnose or treat illness or injury. Okay, so again, it says including CHWs. And this is, so my point here is to emphasize this is not specifically for community health workers, but it does include them. And this is important from an advocacy perspective. And so this slide here, we're just, a quick overview of the timeline here. In August, the National Association hosted a webinar, and you can view that on our YouTube channel. We prepared public comment to submit before the comment period was over, and you can also view our statement that we submitted on the natural website. And then the rules were published in early November, and they go into effect January. Next slide. So in terms of what the National Association focuses on in our advocacy, generally speaking, but certainly in the statement that we made to CMS, we're really focused on preserving and promoting the integrity of the CHW profession and the workforce and the movement, drawing upon our 6 pillars that help explain the nuances of the CHW profession. And our statement, we really, I think the community-based workforce pillar and the historic and diverse pillar really felt salient. Next slide. And here is a brief summary of our recommendations. Our statement was like 11 pages, which was not totally unlike other organization statements, but here are some of the main recommendations. We really wanted to see the American Public Health Association, APHA, CHW section policies in the final rules for community health work integration, principal illness navigation, and social determinants of health services. They see the role for CHWs in all of those areas. We want CMS to publish guidance and ensure that there is technical assistance available to billing entities and non-billing partner organizations like community-based organizations that employ CHWs to help eliminate administrative and billing barriers to participation in Medicare and Medicaid programs that CBOs definitely experience. And additional CHW employers that may not bill insurance directly. This is where the majority of the workforce is employed, so this is really important. We also want CMS to ensure that the covered services really sustain a full range of core CHW roles according to the CHW Core Consensus Project's recommendations. And the APHA policy, it's number 20227, but it's a strategy to address systemic racism and violence as public health priorities, training and supporting community health workers to advance equity and violence prevention. So we're really hoping, it's wonderful that CMS is going to be, they're seeing the value of CHW services. We also want them to see the value of the whole scope of core roles, right? So we want to see CHWs sustainably paid to, operate in their roles that address community level priorities and strengths. We want to see payment for CHWs in their roles that promote the health and well-being of individuals and families and communities, prevent multiple forms of violence, and promote health equity across all levels of sociological influence, from like community, individuals and families, organizations, communities, and at policy levels. Realistically, we knew that CMS wasn't gonna be like, okay, we'll pay for all of those things, because, you know, the services are, the payment is tied to individual level services, or at most like small groups or classes, like education classes. Does that mean we stop advocating for sustainable payment for the full range of core roles? No. So even though we knew CMS wasn't going to turn around and just pay for every single possible thing community health workers do from medical reimbursement standpoint, we still make the statement. So the last recommendation I want to highlight here is that when we're looking toward measures to address quality assurance, right? We know this is coming, that we know like there's going to be a desire for employers to be looking for a set of like, just tell me what to do. How do I comply with whatever standards I need to ensure that we don't get any claims denied? So our recommendation on that point is to look at quality assurance from a standpoint of we need to consistently measure before we're getting to a place of standardization. The work is certainly underway, but it's incomplete right now to develop across the board standards. But there's tremendous value in consistent measurement of beneficiaries and communities and the CHW workforce's well-being. And so we really want to see CMS promote the use of common process and outcome indicators and constructs developed through an evidence-based and CHW-driven national consensus process, such as those recommended by the National Common Indicators Project, which is now called the CHW Center for Research and Evaluation. Okay, thank you for that. Next slide, please. So yes, again, this is a huge deal that really presents some very exciting opportunities. I can't help but think of it as groundbreaking and revolutionary. Like, I feel like this is going to revolutionize the way community health workers are financed. And it feels a little cheesy saying that, but it was about 7 years ago that I started working to address CHW sustainability through the Medicaid payment and reimbursement angle. And there's been a lot of developments along the way, but certainly over the last 7 years in my involvement, this feels like the biggest that I've seen. And I know there's many folks in this room specifically who've been in this work for a lot longer. And so I wonder what their perspectives are on this. I know we've talked about it a lot, but if you see it as much of a big deal as I do, and I know a lot of us in this room do. So opportunities here. This is really an opportunity for one more potential funding stream that could help sustain CHWs and programs. It could also have a domino effect on the minimum covered benefit for Medicaid and has the potential to influence private payers. Potential challenges. We might see some unbalanced rates of growth in CHW employment in critical sectors, more so than community-based employers, which more CHW jobs is a good thing. And the diversity of our workforce is one of our strengths. So we want to see this sustainable payment option accessible to all community health workers, regardless of the sector they work for. As I mentioned earlier, there's just some CHW roles that this reimbursement model is probably never going to cover because it's not tied to an individual beneficiary, right? So community level and policy level roles wouldn't be able to be funded in that manner because you can't tie them back to an individual beneficiary. So that's a potential challenge. And we also see some opportunity or potential for inadvertent co-opting of the CHW profession. I think some of that is due to potential misunderstanding about what the rule means and who qualifies to participate, right? So earlier in my presentation, I started talking about what is CMS, what's their approach? What are they really focusing on? Are they focusing on the profession of CHWs or the services? So it's the services, right? And they're talking about auxiliary personnel, which includes, but it's not limited to community health workers. So the codes for CHI or community health integration, that you don't have to be a community health worker to participate in those, but it includes them. So we're already seeing a bit of a misconception because I think there's just in general, there's been so much excitement and attention on the workforce that, you know, we're making this connection to the workforce and what it means for us. I think what that's translating to is a misconception that it's specifically for community health workers. So if you're an auxiliary personnel, you may believe you need to be a CHW to participate, but that's not the case. Certainly, if you're another member of an interdisciplinary care team, and you also have requisite qualities of a CHW, by all means, get cross-trained as a CHW. But what we don't want to see is just across the board, like blanket cross-training of all staff that are auxiliary personnel as CHWs, without regard to their connection to community. This is another key strength of the workforce that really makes us unique. And so, yeah, from that national advocacy perspective, we want to see that integrity upheld. All right. Next slide. Okay, so looking at a broader sustainability picture for the workforce, the components of sustainability, you know, it's really more than financial sustainability. And here are some aspects to consider, just to name a few. I would love to see, you know, for folks to let me know what I've missed in the chat. Certainly with the opportunities and challenges, feel free to add all of your ideas into the chat of, you know, what have I not covered? What do we need to be thinking about? But for sustainability, you know, for funding to actually be sustainable for CHWs, what it would have to have the impact of is essentially equitably distributing and redistributing resources and funding for the following things. So it's not just funding CHW positions. You know, we need those positions to have thriving wages and comprehensive benefits packages. They also we need to fund supervision for CHWs. There's a bunch of different types of supervision that CHWs are often engaging with, you know, especially in a clinical community partnership situation. You may have your employer at the community-based organization, your supervisor there. You may have your team lead at the clinic, that supervisor. You may have a practice supervisor who's doing like a reflective and trauma-informed supervision to help process some of these potentially re-traumatizing or traumatizing situations that community health workers find themselves in just the normal course of the work. Drawing upon your own lived experience, you know, you never, that's always a potential to encounter something that touches on previous wound or current wound, or just, you know, it's intense work sometimes. So there's that type of supervision. And then a billing supervisor, you know, a physician or a licensed medical professional. CMS has made it pretty clear that that's part of the new rule, is that you need to be connected somehow to a billing practitioner. So there's costs involved in all of that, right? So then we need program costs to be covered for employers. So what does it actually cost to be in a position as an employer to provide CHW services beyond just the funding their position and their supervision? Program costs, you know, we need bus tickets and like various resources to actually like have a program, right? We want to be supporting CHWs to enact a full range of core roles too, right? So not just supporting them to do those roles that are reimbursable. Where does that money come from? Also the labor that's involved in building and maintaining and advancing clinical and community partnerships. That takes time and resources and expertise. We also, you know, in order to sustain CHWs, there needs to be workforce development and capacity building beyond just, you know, and including foundational CHW training at a foundational level, professional development opportunities, and developing a career lattice. CHW research and evaluation, measurement, all these things are really vital components of CHWs as a workforce, as a profession, what it means to be as an employer to be able to deliver CHW services. So there's just like a list of what it needs to do. And then here's some qualifiers of how, like all of these things need to be designed in a way that, you know, have CHW-led implementation and processes to develop. They need to be, again, accessible to all CHW employers, and it needs to benefit all CHWs across sectors. It needs to be driven at state, local, and regional levels. Community health workers, right? And CHW-led organizations and networks should be the go-to technical assistance providers in their local area. So again, let me know what I've missed, but the picture here is that there's just a lot more involved in sustaining CHWs than paying for the services, right? Which is what the CMS rule does. Next slide. And just to further illustrate this, here's that same list again, and some buckets that I'm aware of that can originate from Medicare or Medicaid dollars. So that top one, the medical reimbursement one, these are not to scale. I just had to fit them on the page, and I'm not great with graphic design. But one bucket pays for that, like, you know, they consider it medical. That's the reimbursement that we are talking about with community health integration and principal illness navigation. And then these other buckets, which are all useful to sustain CHWs. And so the moral of the story is it really just is one piece of the puzzle. And with that, I'm going to turn it over to Erica and Tim. Thank you.
Thank you, Angie. Thank you so much for the work that you and like Nachula have done for leading up to this new Medicare ruling. So I would like to introduce you all to our second presenters, Erica Solinsky and Tim McNeil. So Erica Solinsky is a consultant, and she's led many project management services to support like Medicaid policy development. And she's also supported the regional Kansas City CHW collaborative, which led to an effort to establish the CHW certification in Missouri and Kansas. And then with Tim is a healthcare consultant, and he's the founder of Freedman's Health. Tim is known for providing technical assistance to support integrated networks to deliver new models for care that addresses medical risk and social determinants of health in over 26 states. And then he also started and expanded multiple sustainable health programs, including 2 Medicare shared savings program. So I will pass the floor over to Erica and Tim.
Thank you. Thank you for having me. We can advance to my first slide, please. Before my colleague Tim presents in detail on the new Medicare reimbursement code that allows for reimbursement with community health workers as part of a care team for community health integration, I'd like to just provide a short background for everyone on Medicare versus Medicaid for some key concepts and terminology before we dive into Tim dives into some of the more extensive detail on the new Medicare code. So the Centers for Medicare and Medicaid Services is a federal agency, or CMS, and it's the largest payer of healthcare in the United States. The programs which you're familiar with, that are financed or supported by CMS, are Medicare and Medicaid and the State Children's Health Insurance Program, and CMS supports the health insurance exchanges as well. What we want to provide for you is just a level set and key background information on Medicare versus Medicaid, since they both provide critical coverage in the United States. So they cover the largest number of individuals to provide healthcare to the largest number of individuals in the United States. But there are key differences in those programs in terms of how they are delivered and who can receive those benefits. So the next several slides will just provide that high-level overview. We want to note that there are pathways that can be used to incorporate community health workers into the delivery of care in both of these programs, but this webinar will primarily focus on Medicare. Next slide, please. So Medicare is a national health care program. It covers more than 60 million people, more than 65 million people. And generally it provides coverage to older adults, ages 65 and older. It also provides coverage to individuals under age 65 with certain disabilities and individuals who are any age with end-stage renal disease or permanent kidney failure. It has 4 parts. So when you hear about Part A, Part B, Part C, that is how Medicare kind of delivers its benefits and categorizes them. So Part A is generally what you consider your hospital services. So inpatient hospital, skilled nursing facility care, home health, or hospice. Part B, considered more outpatient services. So you think about your doctor's visits or medical office visits, emergency care, ambulance care, medical supplies. That's what's covered by Part B. Part D, I'm going to skip Part C for a minute. Part D is prescription pharmacy benefits. And then Part C is Medicare Advantage. So this is when the Medicare benefits are delivered through a managed care organization that partners with CMS or contracts with CMS to deliver the services. And a Medicare Advantage plan must cover Part A and Part B services, but most cover Part D as well. And so similar in a Medicare Advantage plan, similar to a private health insurance company, you would have to receive benefit services through their network of providers. And so this is different from original Medicare, where you would enroll and receive Part A, Part B, and Part D, with CMS paying for that care. Next slide, please, directly. You've heard a lot of talk about auxiliary personnel. And there are opportunities in Medicare under specific care management models to include to allow auxiliary personnel to deliver services or provide support to the care team under general supervision of a clinician. This is kind of an important aspect that allows community health workers time to be billed under Medicare for these specific care management models. The new code for community health integration models some of these care management models, and Tim will be talking about that in more detail. And I think what's important, though, is that all of the pathways require clinical supervision to some degree and integration. Next slide, please. Now, Medicaid is different from Medicare in that it is, let's kind of jump around here, but it is Established and managed by the states within broad federal guidelines. So CMS has oversight over the delivery of Medicaid by the state, and it is jointly funded by states and the federal government. And in terms of who can qualify for Medicaid, it differs than Medicare because you have to have what's called a categorical eligibility as well as an income eligibility. So, categorical eligibility would be you have to, for example, children, caretaker relatives or parents of those children would be a category. If you're older adults or persons with disabilities would be a category. And some states now, after the Affordable Care Act, are able to cover adults who are not aged as well. And so that is another categorical eligibility pathway. Now, you also have to have at or below a certain income level to qualify, and these are set by states, generally by the federal poverty level, which varies by household. And so states can set those, and they can be at, below, or above the federal poverty level. It's important that Medicaid provides coverage to more than 84 million people. And this would include individuals who are dually eligible. That means they have Medicare for their primary coverage, and Medicaid would offer long-term care costs coverage or cost-sharing assistance for those Medicare co-pays. Medicaid is the largest insurer of long-term services of support in the nation. So that means nursing home care or in-home services and support for long-term assistance needs, long-term care assistance needs. The way Medicaid offers benefits is different as well. So it has a standard set of healthcare benefits that must be offered. That's written into federal rules. And these include inpatient or outpatient services, nursing home care, and then each state may offer an optional set of benefits, which will include prescription drugs or physical therapy. And again, Medicaid is the largest payer of long-term care and supports. So it does provide critical benefits to individuals with long-term care needs. And then finally, states similar to Medicare Advantage may contract with managed care organizations to manage the delivery of care of Medicaid to Medicaid clients. So hopefully that provided a nice, simple background of the difference between Medicare and Medicaid. The focus of today's webinar and what Tim will talk about will be Medicare and the new community health integration code that provides a pathway to bill for community health worker time. And so thank you for having me, and I'll pass it over to Tim.
Great, thanks so much. So I'm going to go into much greater detail on the much anticipated calendar year 2024 physician fee schedule rules. Next slide. So the first thing that I want to highlight, first of all, there's the link to the data that I'm presenting on the screen. But when we talk about Medicare, I want to level set so that we know what is the universe of Medicare mean. And this data is current as of November 2023, that there's a little over 66 million people in the United States that are eligible for Medicare. And that is split up between those in original Medicare that have Part A and Part B, and those that have Medicare Advantage. You see that as of November of 2023 is skewed towards those in original Medicare, and then the balance, so 51.6% are in original Medicare, 48% in Medicare Advantage Part C, which includes special needs plans. So as that relates to these rules, the rules take effect January 1, 2024, and every Medicare beneficiary that has a health-related social need is eligible to receive these services. So that's roughly over 34 million people in the United States. Now, as it relates to Medicare Advantage Part C, or special needs plans, the uptake on that will occur from now until 2025, where all Medicare Advantage plans and special needs plans have to cover all Part A and Part B services in the calendar year 2024 physician fee schedule by January 1, 2025. So that uptake will grow. Next slide. So what does this all mean? I'm going to go into great detail now. Next slide. So it is a Medicare Part B benefit, and the split between Part A and Part B. Part A basically generally covers institutional care, such as hospitals, skilled nursing facility care, hospice, and some other things are all covered under Part A. Part B is generally the outpatient benefits. So every Medicare beneficiary that receives outpatient care, like going to the doctor, getting x-rays, labs, those things, as all part of their Part B benefits, and Medicare Advantage plans cover those services. This is a Part B benefit. It is a permanent benefit, so it's not a temporary benefit. So it's not like if the administration changes, will this all go away? This is now a codified benefit in the Medicare program under Part B. Next slide. Because it is a Medicare Part B benefit, it's important to understand the rules around Medicare, and these rules apply to all Medicare Part B benefits, not just these rules. And all Medicare Part B services have an annual deductible. That deductible amount changes each year. The calendar year 2023 annual deductible is $226. And what that means is before Medicare covers or pays for any Part B services that a beneficiary has, the beneficiary is responsible to first meet the deductible, meaning they have to cover $226 out of pocket, or if they have a Medigap plan, the Medigap plan will cover that deductible. So if on January 1, we deliver these new services to someone and they have not met their deductible, then there would be the cost, the reimbursement would have to come from the beneficiary as an out-of-pocket expense to meet their deductible unless they have a Medigap plan. In addition to that, there's a co-insurance requirement that extends all the time, regardless of deductible, and that is 20% of allowable charges. So if a Medicare beneficiary goes to an outpatient clinic and receives a primary care visit, and that visit reimburses from Medicare for $100, the beneficiary is subject to 20%, or in that instance, the example I gave, $20 out of the 100 would be the responsible cost, out-of-pocket cost share to the beneficiary. Most Medicare beneficiaries and original Medicare have a Medigap plan. I have examples there on the screen, including AARPs, a well-known plan that's actually operated by United Healthcare, TRICARE for Life for the veterans. And if a person is duly eligible for Medicare and Medicaid, then Medicaid becomes a default Medigap plan, and then Medicaid would pay the annual deductible and the co-insurance allowable charges, depending on some additional rules. But that's generally the way that works for dual eligibles that have both Medicare and Medicaid. This is important to know because if you're a community health worker or a community-based organization is contracted with a provider that's delivering these services, you also have to understand the rules around payment and how payment is derived, so that because if your contract with that healthcare provider is tied on collections, you need to understand how collections flow from Medicare. Next slide. The key benefits as described, there's actually there's 4 key benefits. The main ones is community health integration, something called principal illness navigation that's not tied specifically to health-related social needs, and another one called principal illness navigation peer support. And I'll give examples of or an explanation of the differences. The way that these benefits are structured is very similar to the chronic care management benefit that was originally approved in 2015. And the general theme of how those care management codes are reimbursed. It is time-based billing. The time-based billing occurs per calendar month per beneficiary, as was stated by the presenter from the National Association of Community Health Workers. It is tied to services delivered on behalf of a beneficiary. So I'm delivering services to address health-related social needs for Mary, and then I'm capturing the time that I spent working on behalf of Mary, and then that's aggregated, or the sum total over the calendar month determines how much we bill Medicare for services delivered to Mary. and then general supervision is approved for these codes, which I'll go into much greater detail in an example later on. Next slide. Important again to understand the way that claims are paid. This is a Medicare benefit, so it is paid based on claims. Next slide. Whenever services are rendered under the Medicare program and with Medicare Advantage plans and special needs plans, the eligible provider must file a claim, and they file a claim under their tax ID. The claims are primarily filed electronically using something called a CMS 1500. When these services are delivered, it would go on a claim that's filed electronically by the provider. Reimbursement is paid back to the provider based on time, and the time that is used to determine the billed amount can and should include the work of the community health worker addressing the needs of the said beneficiary. Next slide. Can community-based organizations or community health workers bill directly? Specifically, no. The services can be delivered under general supervision of an eligible provider that's enrolled in the Medicare program or contracted with the Medicare Advantage or Special Needs Plan, and they can have a direct contract with a community-based organization or community health worker to deliver services. I want to just point out that CMS specifically stated in the rules that Medicare providers should consider contracting with community-based organizations that employ community health workers and other types of organizations to deliver these services. And they give examples of what community-based organizations look like, what that means. And they also provide a description of something called clinical integration between the Medicare provider and the community-based organization to deliver these services in a compliant manner. And I will provide an example of what that looks like later on in the presentation. Next slide. So the first benefit is the social determinants of health risk assessment. And as I'm going through these services, they really structured these benefits to really mirror the way that healthcare is delivered, where a person reports to their doctor. There's a screening or an assessment. Based on that assessment, they identified a need. So let's take the example of hypertension. They screen the person for hypertension. They determine that there is hypertension, so then they treat it. Then they come up with a treatment plan, maybe medication or lifestyle changes. Then they reevaluate to see, was there improvement? This is really structured the same way. Next slide. So first, there is a screen or a risk assessment. There's a Part B benefit, and it has to occur in addition to a medical office visit or psychiatric diagnostic evaluation or something called health behavior and assessment. Essentially, the eligible Medicare provider is delivering a medical service or clinical service to a beneficiary. During that service, they can complete an evidence-based screen for health-related social needs. They gave examples of two types of screens. One is the Accountable Health Communities tool, and the other is Prepare. And then based on their findings, the provider document the findings of the risk assessment in the electronic medical record. Next slide. This risk assessment must be performed as part of the medical office visit that's done by the clinical provider. There is a specific HCPCS code that was created for this, G0136, and the rate is about $18.44. But remember, this is in addition to the medical visit. So if that provider was doing a standard medical office visit, they'd be reimbursed for the medical office visit, roughly $150. Then they'd separately be reimbursed for doing the social determinants of risk assessment, which would add an additional $18.44. Given that that provider used an evidence-based screen and documented the findings in the electronic medical record and then put on the claim form G0136 to be reimbursed. Next slide. One thing before I go into the community health integration, because this is the actual intervention to address the health-related social needs. It's important to note that social determinants of health risk assessment can be done at least once every 6 months. So it can be repeated, and then the provider can work with a community health worker or community-based organization to assist them with doing the screen. And what we found from the work of the Accountable Health Community Project, which was another CMMI demonstration that I had the pleasure of supporting, that oftentimes when a clinician does the screen, that findings may not be complete. The person may not want to disclose to their provider that they're the victim of interpersonal violence, or they may be embarrassed that they don't have food for their family. But then when they meet with a trusted community resource, they may provide additional information. That information, for purposes of these benefits, needs to find its way back into the electronic medical record. Next slide. Based on the findings of the social determinants of health risk assessment and the documentation in the EMR of what the needs are, then there is separate reimbursement under this set of benefits called community health integration, which pays for the labor of auxiliary staff, which can include community health workers, but is not limited to. So it's really a practice level decision on what auxiliary staff are assigned to provide community health integration services. When those services are delivered by auxiliary staff that can be community health workers, then it is billed based on time. And there is no cap on time, but it is billed in increments. The first increment is 60 minutes. So the first 60 minutes that the community health worker spent working on behalf of the beneficiary to address the identified health-related social needs is reimbursed. And then every 30 minutes thereafter is a separate reimbursement. And it is not billed, it's billed once per calendar month. So if I provided 90 minutes over the course of the calendar month, I'd bill for the 60-minute code and separate for the 30-minute code for that single beneficiary. And there's a separate claim per month for every beneficiary that received community health integration services to address their health-related social needs during the calendar month. Next slide. Here's the list of reimbursable services that can be considered community health integration services. So you can see there's a broad range of services. I want to highlight some that I think they're all important, but I just want to highlight some of these. Coordination of care transitions. So persons that are admitted to hospitals or nursing facilities or emergency departments during an observation stay, moving them from hospital to community is considered transitions of care. So helping to coordinate care transitions, particularly when they are impacted by health-related social needs, is a reimbursable event. Facilitating access to community-based social services. I'll give a very detailed example when we go to the later slides. But those are some that are important. In addition, building patient self-advocacy skills, health education, and facilitating behavioral change, particularly for persons who are impacted by low health literacy or other things that are impacting their ability to manage their conditions. All of these things can be billed when interventions are delivered to address these their needs, and they fall into one or more of these categories, as long as one, the need is documented in the EMR based on a screen. If it did not occur during the medical encounter, then the community health worker needs to alert the provider of other needs. Then based on those needs, there's a plan, and that plan includes targeted community health integration services that are delivered by the community health worker, and the time spent per calendar month is then directly reimbursable. Next slide. So here's the rates for the community health integration services. So you can see, I mentioned that there's a code for the first 60 minutes. That is G0019. That is the code that the healthcare provider would put on the claim form. When they submit that, then the rate would be roughly $79.24. I say roughly $79.24 because Medicare has an allowance that changes the rate based on the location where services are delivered. So there are multiple things that are taken into account. It's not a huge variation. It is a slight variation, usually $1 or $2, sometimes a few cents more or less, but they do take into consideration, I'm based in Washington, D.C. So the cost of delivering healthcare in Washington, D.C. is much higher than the cost of delivering healthcare in rural Alabama. And so the rate for the cost to deliver services in Washington, D.C. is a little bit more than the national rate, and the rate in Alabama may be a little bit less. So it's also important to understand what is the rate based on the geographic location you're providing services. There's that rate for the first 60 minutes, and then for every 30 minutes thereafter, there's additional reimbursement with no cap, no limit, as long as the person has a need and the community health worker is addressing the need that can be substantiated in the record. You keep adding additional G0022 for every additional 30 minutes. And that goes on as long as the need occurs or the month ends. And then it's totaled at the end of the month. So I spent hypothetically 5 hours, because I have a very complex case for a person who has complex medical conditions and been evicted, and we spent time stabilizing the house. I spent 5 hours. I billed the first 60 minutes and then every 30 minutes, totaling up to 5 hours, as long as the documentation substantiates the service delivery. Hypothetical example. Next slide. The process flow model, next slide. This is a hypothetical or sample process flow for the delivery of community health integration service. So you see these are numbered 1 to 8. So if I start at the top left-hand corner of the page, there is a Medicare beneficiary that is not, just highlight again, Medicare, you can be eligible for Medicare by age or by disability. So everyone that's eligible for Medicare is not a senior, but this just so happens the picture there is an elderly person. But that consumer is screened by clinical staff and identified as having a health-related social needs. In section 2, the primary care provider completes the social determinants of health risk assessment. So that's that first billing point. They identified needs and then made a referral to a partnering community-based organization that deployed a community health worker to meet with the beneficiary. There's an electronic referral that's sent to the partnering community-based organization that outlines all of the health-related social needs that were identified in the medical office visit. Then in item 4, you see that I recommend that the community health worker complete a secondary health-related social needs screen. That secondary health-related social needs screen is based on our experience with the accountable health community risk assessment. So that secondary screen identifies additional needs that the person may have to complete the person-centered plan. The person-centered planning process to address the needs that a beneficiary has can be incorporated into the community health integration time set. So me completing the additional screen to help me develop the person-centered plan in item 5 is reimbursable time based on monthly calendar month billing to complete the person-centered plan to address the health-related social needs. But that needs to be clearly documented in the record, both the purpose and the outcome is completing item 5, the complete person-centered plan that takes into account all the health-related social needs that the person may have. Then once I have a person-centered plan, I now need to address their needs. Those needs can be achieved, or addressing the needs can occur by blending and braiding resources to address health-related social needs through social care navigation. So these codes do not pay for, let's say they won't pay for a bus token, they won't pay for meals if someone needs food, and they won't pay for the first month's rent or deposit, but they will pay for the labor for the community health worker to find a resource that then can be used to pay for the transportation or pay for the housing or pay for the food. And the labor expended to identify those resources is captured in the time, documented in the record, submitted on a claim, and then reimburse back to the provider who has a third-party contract with the community-based organization or the community health worker. That is then shared back with in the electronic medical record in item 7, and then the final throughput, section 8, is that the community health worker, in order to be fully integrated with the clinical practice, should be regularly meeting with the care team, discussing the impact of the community health integration and the treatment goals. Oh, I think I see them over time. So I guess I can't go into the example. Next slide. I think I'm over time. Do I have time to do the case study or hold that case study?
We don't have time for the case study, but we will be sharing the case studies with the recipients with the partners on here as well too. So we will have the slides up. Sorry, unfortunately, we started a little bit later, so we are gonna have to cut Tim's time a little bit shorter. But then do you want to, are you able to continue with the CHI interventions deployed without sharing the case studies?
So the final part of the presentation is the case study. So
Okay.
Mungshi, how much time do I have? I can shorten some if needed so Tim can do the case study.
Okay. You have 10 to 15 minutes. Do you think you'll be able to do yours in like 10 or 15 minutes?
Yes.
Okay. So that gives Tim, that will give you about an extra 5 to 10 minutes. Is that enough for you?
Absolutely. So we can go into the case study. I'll do it in 5 minutes.
Awesome.
Next slide. Thank you all so much. So this is Gertrude. I think the case study is going to crystallize the concept. I hope so. So Gertrude is a 62-year-old female with a history of bipolar disease, homelessness, food insecurity. She has frequent ED visits for uncontrolled diabetes. And as I point out again, she's 62. So she's yet less than 25, eligible for Medicare by diabetes. Because of her homelessness and food insecurity, she's unable to store her insulin, manage her medication because of the transient housing. She doesn't have access to recommended dietary restrictions because at the low barrier shelter, they provide her with donuts, muffins, and juice for breakfast in the morning, which does not align with a healthy diet for diabetes management. And she often has her insulin needles and glucose test strips stolen at the shelter, which also impacts her ability to manage her diabetes. So that's the framework for the case study. Next slide. She has a visit with her primary care provider. The primary care provider on the screen completes the social determinants of health risk assessment. So that's the first code set. During that social determinants of health risk assessment, the primary care provider documents the identified needs that are impacting the ability to manage the diabetes. Those specific things are housing insecurity, transportation, poor health literacy, and poor medication adherence. And the tie-in has to be the social need is impacting the ability of the provider to successfully manage the diabetes. You can't address social needs just for the purposes of addressing social needs, but there has to be a specific tie-in to the plan to treat the medical condition, in this case, diabetes. Next slide. The primary care provider completes the diabetes treatment plan and then documents that in the record. The diabetes treatment plan includes adhering to a low sugar, low carbohydrate diet, improved medication management, daily glucose testing, and adherence to scheduled visits. So you can, again, see the tie-in to the health-related social needs and the inability for the beneficiary, Gertrude, to do the things that are recommended in the treatment plan. Next slide. So here's our champion, the community health worker. The primary care provider refers to the community health worker. In this instance, the community health worker is provided by a community-based organization that employs community health worker and contracts with the primary care provider to deploy those community health workers. That assigned community health worker meets with the primary care provider and develops an individualized plan to, one, address the medication adherence, address the housing insecurity, address their inconsistent access to food and transportation. Again, the direct link to the treatment plan, and now the community health worker is going to achieve some objectives that will help achieve the goals that are in the plan, which is improve the A1C. Next slide. So the community health worker then deploys a range of social services by providing social care navigation to address the needs. The social care navigation in this instance, it means addressing the housing insecurity. So the community health worker identified a local HUD-funded continuum of care, identified that they had emergency vouchers, then contacted the agency to find out the application process, assisted the beneficiary with completing the application for an emergency housing voucher to stabilize the housing. Next, the community health worker needed to address the food insecurity. And so the community health worker accessed the USDA website to identify the USDA emergency food assistance programs in the area and assisted the beneficiary with applying for SNAP benefits. The community health worker, in order to get improved adherence to the medication treatment plan, the community health worker wanted to set up medication reminders on a cell phone. The beneficiary did not have a cell phone, so the community health worker applied for the FCC Lifeline program to get them a free cell phone. And then once a cell phone was secured, the community health worker set up text reminders so the beneficiary can remember to take their insulin. And so all of these activities addressing the housing, the food, the cell phone, the setting up the reminders are the community health integration services that were performed on behalf of the beneficiary. The total for each encounter, they capture the time, they document what was performed, the outcomes, they aggregate the time per calendar month, and then bill under the rendering provider to Medicare to receive reimbursement for the labor extending these services. Next slide. That community health worker participates in care team meetings where they actively participate in discussing what things that they've done, how that will impact the care as a trusted member of the clinical care team. And again, this meets the clinical integration standard between the community health worker, the CBO, and the treating provider, all working as a team to achieve the ultimate goal, which is improving the diabetes management for this beneficiary. Next slide. The documentation for the community health worker for the community health intervention integration services must include each intervention deployed to address the health-related social needs. So they don't write a summary at the end of the month and say, I did all these services, and for that time, I spent 3 hours. Every single time that community health worker is working on behalf of the beneficiary. So December 1st, December 4th, December 15th, there's a separate encounter. That separate encounter captures the start time and the stop time and the total time for each encounter. At the end of the month, all of the time is aggregated per beneficiary, and then the total time spent that calendar month determines how many codes of services are billed under the community health integration codes. Next slide. And then under a third-party contract arrangement, because this is an example of the community health worker being provided to the clinical practice by a trusted CBO. In this instance, the clinic contracted with the United Way. The United Way provided a team of community health workers to support not just this clinic, but other clinics in the area. Those trained community health workers integrated with each practice, and the United Way, through a third-party contract with each practice, submits an invoice of the total time spent providing community health integration services per beneficiary. And then when that reimbursement is obtained from Medicare, the clinic then reimburses United Way for the services rendered by the community health workers delivering community health integration services. So thank you all for the extra time, but that's the case study for community health integration.
No, thank you, Tim, for an abundance of information on this night. It's a good thing we didn't cut off the case study. We really needed that part in order to really get better information on how to implement this. So thank you so much, Tim. And then I will also pass it on to Erica to talk about the toolkit.
Thank you. And I'll go quickly so Jackie has time, but Tim and I actually authored a toolkit, reimbursement strategies for employers of community health workers through the Kansas City Regional Community Health Worker Collaborative that's available to folks as well. Next slide, please. The toolkit was drafted before the new Medicare rule, and we drafted it just to bring awareness to existing funding opportunities within the current healthcare market that could be leveraged to bill for community health workers' time. And so the toolkit is available on the Mid-America Regional Council website, which is a local council of governments in the Kansas City region. And it's really drafted to accommodate various levels of understanding of healthcare billing. So we have basic primer chapters on how healthcare is funded in the United States. How is it billed? For example, what is fee-for-service reimbursement? But then we have an extensive appendix on language within the toolkit on reimbursement pathways for community health workers. And we acknowledge as best we can different practice settings. So community-based organizations, FQHCs, and what might be those pathways for those different practice settings. Next slide, please. So Tim and I drafted this. Just want to acknowledge we had an advisory committee and outside reviewers, and it was supported by the Health Forward Foundation in Kansas City and the Mid-America Regional Council. Next slide, please. Oh, we took off one of my slides. Anyway, there's 7 chapters in there. There is an appendix that looks at different billing codes like chronic care management, transitional care management, and other different reimbursement codes that could be utilized to bill for community health workers' time within a clinical care team environment. So know that resource is available to you. Thank you.
Sorry about that. Thank you, Erica, for the overview of the toolkit. So we will go into our last presenter, Jackie Catron. She is the director of the CHW section for the Kansas Department of Health and Environment. So I will pass it on to you, Jackie, to talk about your sustainability work in Kansas.
Thanks, Mungshi, and I will try to keep this short. So next slide. Okay. When we were looking at writing for this grant, the main goal for Kansas and KDHE was CHW sustainability. And so Kansas had been working with community health workers and had a coalition set up prior to the 2109 or 2103, another grant funding that we have. And so they kind of already had some goals in mind. We were lucky to get this grant along with another, and we did braided funding for 13 different subrecipient organizations that include federally qualified health centers, rural health centers, primary health clinics, private health clinics, and then one community-based organization. So you can go to next slide. That reimbursement and sustainability looks different for every organization. Like everyone is kind of echoed, different organizations have different reimbursement pathways, different rules they have to follow, and you could get into, Tim could probably go on for 2 more hours on all the different billing rules. That is really complicated. So one thing we did when we first started was use Erica and Tim's toolkit, because this was prior, as Erica said, to the other sustainability options. So that Appendix C has different categories in there, and then worked with our clinics on thinking ahead about these different pathways. So chronic care management, transitional care management. We have CHWs trained under some pre-diabetes prevention programs and self-measured blood pressure monitoring, the disease self-management, remote patient monitoring. So thinking ahead on this, that they potentially are going to have different pathways. So we already have clinics training their CHWs in a couple of these areas and as backups for sustainability. Next slide. And so first thing to say on this is, like, as other people have said, these are just general national rates for Medicare. And I actually noticed on Tim's that I crossed 2 numbers, 7294 instead of 7924 when doing this. But we recently in July got Medicaid sustainability pathway for CHWs in Kansas. And so looking at Medicaid and Medicare, and again, these are national rates, and then we also have FQHCs and RHCs that have to bill differently. So this is just a basic, really simple tool to show some of our clinics, but the billing is way more complex than this. There's a lot more things that have to be included, the supervision, there's travel, there's documentation. And so this is just a simple tool, not to get into a bunch of finer details on this. And though the other thing with our clinics to think about with this is, as you can see, I only did like 19 hours of billing. So we've talked with them about, do you want to do 50% grant funded and then 50% of your CHW's time can be used as billing, and we can help work through some of these billing issues that are going to come up when anyone starts billing a new code. So also knowing that the CHWs typically work with more than 10 patients at a time. We all know that, and that these hours are going to vary. So looking at this, you would think these patients are typically probably in a crisis mode. And so the CHWs are going to be working with them a lot more in the beginning, and then that's going to go down to maybe weekly or every other week, once a month. And so that varies with their clients and with their clients' needs, and with the CHWs, how many patients they are working with. And so our Kansas plan right now has some different caveats. They can only bill 2 hours a day of time. They can only bill 12 hours a month. And so keeping that also in mind, there's scope of work and supervision levels that are tied to our Medicaid, along with, as Tim explained, in the Medicare. Next slide. So one of the big things to talk about that I wanted to bring up is this work could not have been done without the partnerships and the collaboration across Kansas. And so there are many different partners that were all working towards the same goal. So government, healthcare, philanthropy, nonprofit, community-based organizations, the coalition. We all meet regularly to discuss the projects we're working on, the goals, and then recently developing like a work plan between multiple partners. So next slide. The work plan is based on, again, the goals that we all have: grow and sustain the CHW workforce and how health equity can look across the state of Kansas. So their organizations are working with the Division of Healthcare Finance originally to get that state plan amendment approved, and now working to help to improve that and make it better, a higher rate, allowing FQHCs to bill those types of things. We also work a lot with the CHWs and what they need and what they want. And so what educational resources do they need for their scope of work? What is it that they're allowed to do and not do? And how can we train and educate employers on that so they're not being pulled to do things that are not in their scope of work? How to document, because documentation, we have to have documentation, how to find resources, and most importantly, how to tell their story. And so people can understand why they are so important and that they deserve a livable wage and a sustainable future. Next slide. So this was just one part of our work plan. The biggest part related to this is how we were doing that with increasing the adoption of the state plan amendment through education outreach and improved technical assistance. And so again, we realized like not one organization can do all this. And so several different organizations are reaching out to partners across the state and explaining community health workers how they can reimburse, how that looks in different organizations, different communities. Yeah, next slide. I think that's all I have.
Thank you, Jackie, for sharing about what Kansas has been doing with their CHW sustainability work. So can I go to the next slide, please? So what are some of the next step as like CHW or CHW programs that want to explore on Medicare reimbursement, right? So we really want to elevate the continuation of educating ourselves on the implementation of the new Medicare ruling change and prioritize building relationships between providers and CHW employers with also your local CHW networks and association. Next slide, please. And I do want to mention that Envision is also doing sustainability work. So Envision has been working on sustainability with our recipients. We are currently working on an overall sustainability toolkit, which emphasizes the importance of CHW leadership development with power mapping and capacity building with CHW network development and exploring a variety of financial strategies for CHW programs. So not only looking at Medicare and Medicaid, but what are other forms of financial strategies that could be used for CHW programs. So we would like to mention that to everyone. So thank you so much, everyone. Thank you for the participants for joining us today and facilitators as well too, and speakers.